let me see if I'm hearing the two of you correctly then. The trouble with the current drugs is that they're toxic, so you don't want to have to use them if you don't need to. So we're using this monitoring technique to intervene, not preemptively, but kind of preemptive, but really early.
In fact, actually, yes, when we intervene, there's a
it's-
debate as to whether or not, when should you intervene?
Yeah.
What level should you
So,
intervene at?
so you're intervening when you have some evidence that the disease is there. But if you had available a drug that wasn't so toxic, it may be a real advantage to give a truly prophylactic drug.
Absolutely. Okay. So you want to prevent. You don't want to treat at the first sign of infection. I prefer to prevent the infection, because we don't know first, how much, you have to wait until their viral load goes up and you start.
But I mean, prophylaxis is where we've gotten in this field thus far.
For everything else.
For everything
Yes.
else.
Well,
That's
we just
what's
talked
advanced.
about for fungal infection. So it makes sense. And as we come to later on in this program, let's talk about that more. But in order to flesh out a little bit of the discussion about this monitoring, when I ask my house staff to order monitoring for CMV, they have a choice of all of these different tests, and usually you end up getting all of them. And do you need all of them? What do they do? How do we monitor now? What are the various tests available?
So it used, for many years, we used to do the CMV antigenemia, look at the antigen of CMV, PP65 in the blood. We know that it wasn't a really sensitive test, especially
Don't you need white cells?
Right, this is the thing.
Right, it's in the white cells, so you need white cells, and our
patients.
patients often don't. I'm sorry, didn't mean to cut you off.
But absolutely, you're right. So that's why it was insensitive test. So are we detecting antigenemia when it is almost too late, or when patient already have maybe an organ disease or something like that? So now with the era of PCR or viral load, it's very sensitive test. So probably we're catching pretty early reactivation, and we're acting on it in high-risk patient, at least in cohort. Any positive, which is sometimes we treat. And is this affecting outcome? Probably, but we have to see the data for CMV. But we know that patients are not dying from CMV anymore. It's very rare. So the rate of CMV and organ disease, it went down from 20% down to probably 3%, which is great. But still, CMV viremia is still occurring. So what else can we do? So what we did, actually, we were interested to see if someone is already have a good immune system, good T cell, CMV-specific T cell response, are they protected from CMV viremia? This can help us, and I will tell you where, because we conducted a study where we looked at all this very low level of reactivation. And are we over-treating? Are this patient gonna progress, or they're gonna have self-resolution of this viremia? So we did a CMV-specific T cell ELISpot assay, and we found out that at certain level of response of interferon release, these patients are protected from CMV progressing or from even CMV viremia. So this is not validated yet. It's a small study that we conducted, but in the future we have hopefully we see the data in multi-institutional study that we completed enrollment, and this may play a role in the future to help the transplant to determine, does this patient at risk for progressing from CMV, or does they need to be treated for low level, or do they need to be monitored actually if they have good CMV T cells?
So that raises an interesting point, because the PCR assay, first of all, at what level do you need to begin treating? But sometimes we actually have patients that have a negative PCR assay, but have, in fact, CMV esophagitis or something like that. So do you think this modality is going to help?
Absolutely. So it may help us to determine really if the patient is protected or not.
Yeah.
Because this is what the data is showing, that if you have a good CMV T cell response, these patients, they may not need to be monitored also as frequently. But this needs to be validated, and hopefully we hear more about it in the future.
So explain it a little bit more, because I'm not sure I'm quite getting it yet. So what is being actually tested? The T cells, and you're looking to see if they respond to CMV?
Right. So
in vitro.
In vitro. So you're taking the PBMC, you're isolating the T cells, expose them to CMV peptides, PP65, intermediate early antigen, and then you see if they're interferon release, then meaning T cells are enough to protect a certain level, a certain threshold against CMV.
That's an active area
of
of bone marrow transplant research. When do the T cells that protect you from CMV,
Yes.
first of all, did you kill them with your preparative regimen?
Yes.
Or if you did, or lowered them, when do they come back?
Right.
So is that similar to the TB quantiferon test?
Kind of similar of the TB T-spot or the ELISpot test. It's the same kind of, but the T-spot TB test, it tells you a patient already been exposed to tuberculosis, then they will be at risk for infection. This one, the CMV T spot assay, it will tell you, or ELISpot assay will tell you a patient has enough CMV T cell, they are protected against reactivation.
So what's the CMV quantiferon test?
So the quantiferon is kind of ELISA test, different platform to test for same kind of concept, looking at interferon release from this T cell, but a different platform. It's an ELISA test. I would say probably it's not as robust as the ELISpot testing that is done for CMV.
Okay, so but right now, are those being used in clinical practice? Maybe I didn't
Not
get
yet.
that yet.
I would say not yet,
So,
but
okay, so
more to come. hopefully in
Okay,
the
so
future.
so for our listeners, then it's still the CMV viral load by PCR.
No, we've made a lot of progress, but that's our current state is.
And you trigger therapy at what level? I know no one agrees, but you guys are the experts.
So it depends. I think, it depends on the institution. And I talked to many institutions here and in Europe also, different thresholds.
Yes.
This is the problem with the viral load. For us, probably, for cord and haplo or high risk patient, any positive at 2 times, 2 positive, it triggered treatment. Now for low risk, we wait until 1,000 IU per ml or international unit per ml. But other institutions, they go, maybe they have low threshold.
We're still
or higher.
debating with that issue,
Yeah,
I think.
I know.
So again, it comes to, I assume you get your whole team together, Mark, and it's a risk-benefit ideas in there, and they're saying, I think we should treat, and you're saying, wait a second, this patient has no counts, and I don't want to kill the graft.
Well, no, at our institution, we try to set, our whole group gets together to set guidelines, but each patient is individualized.
Right, in different positions.
Yes.
Okay, so.